So basically the choice what we have is mechanical and bioprosthetic. Of course the mitral homograft, once it was used, now I don't think anyone uses, and all the other things are still in a experimental stage only. So I think Madam had already said a lot of things about the valve, but what is the current valves, what in use only I will talk about. The ball and cage has gone off and tilting disc is now remaining only as a TTK Chitra in India. I don't think any other company makes a single leaflet valve, and most of the valves available are bi-leaflet. So what we currently use are the Onyx, Medtronic AP series and St. Jude, and of course the TTK Chitra in Indian scenario. These are all the common valves what we get in Indian scenario. And if you see the bioprosthetic, it mainly the stented porcine and stented pericardial. And these are all the common valves what is in practice now. So we have very limited choices in fact for mitral replacement, whereas aortic there are a lot of developments, newer valves have come in, but the mitral we are still with little bit of a old generation valves only. So if you see the mechanical valve, the prospective thing is it is very durable and very easy to implant. Otherwise we have lot of problems with the mechanical valve. One of the major thing is anticoagulation, and because of the anticoagulation we might end up in a valve thrombosis and catastrophic malfunction, and it is difficult to treat infection if they interact one, and difficult for other surgeries to be performed when they have a mechanical valve and anticoagulation, and some other valves are quite noisy which may be disturbing for some other patients. Whereas bioprosthetic valve, there are no, catastrophic malfunction. It is also very easy to implant and no long-term anticoagulation in most of the replacements. But whereas the problem, the earlier generations were high profile and less performance index, and structural valve deterioration, calcification and tears were very common, and durability and reoperations were the order. And now the newer bioprosthetic valves have overcome some of these problems, like because of zero or low pressure fixation and new anti-calcification treatments and smaller stents, higher performance index, the life of bioprosthetic valve is now extended more than the earlier generation. So you can see here the fresh leaflet looks like this, and leaflet fixed with the low pressure or zero pressure remains almost similar, whereas with the high pressure it is compressed into a thin leaflet. So it definitely affects the performance of the bioprosthetic valve. So same thing with the calcium. Now they had found out lot of things about how to do the extract the binding site, coat binding sites, and formation of stable crosslinks, which are all now either removed, this is inhibited and controlled to have a better long-term result, and because of this anti-calcification treatment, the life of the bioprosthetic valve is extended now. So basically, the material what it was used earlier, the design concept and the process which has caused the improvement. And this is how the native leaflet and pericardium, see, because most of the recently developed valves and better result-oriented valves are pericardial valves. That is because of the basic structure of the material used in the valves. Whereas this porcine, you see, there are 3 layers which are difficult to and heterogeneous. Because of that, there is a problem. Whereas if you see the pericardium, it is predominantly a collagen matrix which is much more homogeneous. So if you see this porcine tissue structure, these are dispersed layered collagen structures which causes more problems. Whereas pericardium is a dense uniform collagen structure, because of the durability gets better. And of course, this all related with the tissue properties where it shows the pericardium is better than the porcine. And now with the technique, if you see with the recent valves, the profile is becoming lower, whereas most of the better ones have 9 or 10 mm, whereas the earlier generation we had a 14 mm. And this is some other thing where the leaflet is broken, not by the surgeon, but it came like that. So a lot of pannus formation happens which affects the valve function. And this parallel leak is mainly due to that infection which causes dehiscence. So if you see, so many people have analyzed the outcomes of survival. If you see basically the 10-year survival for most of the valves, it hovers around 60%. The 80% what they claim, the numbers are so little, it's, we can't take it really with a pinch of salt only, we need to do that. But average we get about 60% in most of the valves. If you see prelim valve related death, in fact, there is no death in fact because of the valve. It is because of the other problems, either anticoagulation or infection or bleeding, or it is, you can't directly call it is because of the failure of the valve function. So technically what they say is true, because 10-year it is about 90% in mechanical valve. And the same way, freedom from structural valve deterioration with mechanical, none of the valves get deteriorated. It remains all right, but then we have other issues only. So most of the valves claim the 10-year structural valve deterioration is close to 100%. And the freedom from thromboembolism, which is one of the problems in mechanical valve, it is close to 80% average. Some of them claim 95, and some of the earlier, the recent Onyx valve claims much better short-term result, but we need to see that in a long-term process. And freedom from hemorrhage is also almost similar, close to 80+% in most of the valves. And the reoperation, not because of the valve, but it is because of the other problems only, mainly anticoagulation, valve thrombosis, but close to 95% they claim in all these papers. Anyway, we need to take with our own judgment, because what they claim may not be the real true picture. So if you see the long-term outcomes in bioprosthetic valve in mitral position on the same headings, see here we see more like structural problems where calcification, here it's a small tear causing problem. And you can see how densely it can get calcified, it almost becomes like a rock. And this one of our patients had a leaflet tear within a year. And tissue valves also develop pannus. It is not the mechanical valve. This is some of the patients where we had seen, you can see the pannus developing over the leaflet, causing leaflet problems. And we had seen recently, within almost 9 months, we had had a pannus developing over a tissue valve causing obstruction. So same, if you see the survival, most of the tissue valve, it is about 50 to 55% and close to 60 at a 10-year. And freedom from valve related death, only 10-year follow-up, they say about 85 or 80% claim they have. And freedom from thromboembolism, which is much higher in tissue valves, which is close to 93 or 90% in most of the studies. And freedom from hemorrhage also, it is much higher with tissue valves at 10-year, close to 99 with the range ranging from 92 to 99. And one of the major problems, structural valve deterioration in tissue valves. So at 10 year it varies with so many different valves. The porcine valve deteriorate much faster, but the pericardial valve lasts longer. Even though each one have different claims, it is about 60%. And freedom from valve reoperation, because of structural valve deterioration, it is mainly valve-related reoperation in tissue valve, which close to 76 to 95 each one they claim. So all these things, if you compare the survival at 10 year with the mechanical and bioprosthetic is almost similar, where bioprosthetic it is better above, less than 40 years, the survival is better. That is because of the other reasons. Freedom from valve-related death, it is 90% with mechanical and about 65 in bioprosthetic. Freedom from embolic events are almost similar, they had said. Freedom from hemorrhage is better with bioprosthetic. Freedom from structural valve deterioration varies. There is claimed 100% and here about 60 to 70%. Freedom from reoperation because of the valve, not because of the other reasons, were 95% with the mechanical and 75 to 80 in bioprosthetic. So if you see the natural history of mechanical valve, there is a constant hazard function, death of 1.5 to 3 patients per year, and major adverse prosthetic events 3 to 7 per year. And the pannus formation, tissue ingrowth and clots reduces functional capacity of the valve. Even though they claim it is lifelong, most of the valves about 10-12 years we find increasing gradients and other things because of the pannus formation. And naturally, for bioprosthetic valve, the structural valve deterioration depends on age and position of the valve, and embolic stroke is much less with them. And the hazard function increases after 10 years, and reoperation contributes to morbidity and mortality in tissue valves. So if you see the guidelines, of course, the choice of valve, intervention and prosthetic valve should be a shared decision process. And the other one, we have a group, class 1 indication. And the main thing is the mechanical prosthesis reasonable for AVR, MVR in patients less than 60 years. Those who have no contraindication for anticoagulation. Bioprosthesis reasonable in patients above 70 years of age. And either a bioprosthetic or mechanical valve reasonable in patients between 60 and 70, which is a gray area, becomes the class 2A indications. And same if you see the European, the bioprosthetic recommended according to the desire of the informed patient remains same as class 1. And the bioprosthetic recommended when good quality anticoagulation is unlikely, remains class 1, and bioprosthetic recommended for reoperation for mechanical valve thrombosis despite good term long anticoagulant control becomes a class 1 indication. Here class 2A is slightly modified. They raised the age limit in European population. So the decisions are based on integration of several following factors: the class of recommendation, level of evidence, life expectancy should be estimated according to age, gender, comorbidities and country-specific life expectancy. In patients aged 60 to 65 years who should receive an aortic prosthesis, and those 65 to 70 years in case of mitral prosthesis, both valves are acceptable, and choice requires careful analysis of factors other than age. So this is a compilation of what I had said. In fact, Japan, they had their own study, and because they had their differing age, the survival, they wanted to have a different protocol for guidelines. If you see this, The Japan have the highest life expectancy, 83.3. Whereas India, the present, according to 2013 data, it is 66.5 years. So I don't think we can take the guidelines of AHA or ESC for our purpose technically. So there are few well-defined indications for mechanical valve. It is preferred in young patients. Life expectancy of more than 15 to 20 years, who require long-term anticoagulant therapy for other reasons like atrial fibrillation or any other issues. And bioprosthetic valve preferred in elderly patients, life expectancy of less than 15 to 20 years, and who cannot take long-term anticoagulant therapy. These are all becomes a clear indication in our practice. So we decide on few of the things. So age and gender in our practice becomes a major factor to decide which one to take. Then the life expectancy, if they have some other medical problems where we are not expecting them to live beyond 10 years or more, then your choice of valve differs. Or if they need some other treatment for the other medical problems, whichever valve suits that condition, I think we need to decide on that. And we need to look at the socio-cultural status and education, especially in our scenario. A lot of patients don't understand anticoagulation properly. And we had seen that putting them on a mechanical valve, half the population comes back with a stuck valve. And we are forced to operate them on emergency with a higher morbidity and mortality. So we need to make sure the population understands what is anticoagulation, how to follow that. And when there is a contraindication to anticoagulation, hypercoagulable will say now lot of genetic studies have come, we can analyze the patient and we can find out who will respond better and who won't. Then depends on that we can select the valve types. And as I said earlier, the complaints, the patient should be willing to understand and follow the instructions very clearly. And like one of the comorbid factors, now we see more and more of end-stage renal patients either on dialysis or patient who had a renal transplant coming up for valve surgeries. Then we need to decide what valve to use in those situations. And the lifestyle. Even some of the very young ones, executives, they travel worldwide and they want a simple lifestyle. They don't want to take anticoagulation, or somebody interested to follow some other sports activities, they prefer a tissue valve. I think what like a class 1 indication you should discuss with the patient and find out what is their lifestyle, what they want, what is the need, then you should select the valve. And finally, affordability also matters, because some of the very good tissue valves cost thrice of the mechanical valve. Whether the patient is able to afford that also we need to look at. And the other important factor in our practice in India is availability of medical services, because we find some of the remote areas don't have facility to check the INR, or some of the time the INR what they check and tell whether it is reliable. Because I know a lot of situation where patient kept on telling the INR is 1.1 or 1.2 in spite of keeping on increasing, and finally they landed up with a big bleed. That means they have never done INR, or the INR what they have done is wrong. Based on that, correcting anticoagulation also becomes very difficult. And technical aspect, of course, we need to look at the anatomical situation of the valve and other things, which valve will suit. In a very, very small LV, putting a high profile valve may be a problem. So you need to look at all the technical aspects of replacement also. So when to avoid, to summarize this, anticoagulation, if not possible, are desirable. Non-compliance for medication or testing. Remote areas for INR management. If they are involved in hazardous profession, lot of our people are coolies and they do manual labor where to put them on anticoagulation may cause lot of bleeding, or wounds, if they don't treat properly, get infected and they are prone for infective endocarditis. And the elderly and short life expectancy, and the people who plan for pregnancy, which we find more and more patients now want to have children in spite of the heart problem, and growth potential cannot be addressed. And situation where we should avoid bioprosthetic, calcium metabolism high like a young population, and life expectancy of the patient is much higher than the valve life. And this is only for history of mitral homograft, of course, which came with a bang after the aortic homograft, especially promoted by Dr. Christopher Eckar. And in fact, he came and operated in our place also on 2 patients. But then, unfortunately, none of the other surgeons could emulate what results he had claimed. Most of the patients had come back in a very early phase with dense calcification for a redo, which slowly made this procedure not attractive. And maybe Dr. Sambat Kumar will be talking on this RAS2 procedure, pulmonary autograft in mitral position, which has not taken off in a big way, maybe because of the availability of the homograft is one, and maybe the expertise needed is much higher valve. Replacement with a mechanical or bioprosthetic becomes a very simple affair. This they need to learn and they train well to do this procedure. And finally, we feel choice of prosthesis should be individualized to each patient. Whatever you categorize, it has to be individualized and each patient deserves what they need. If you understand that, I think your valve selection is going to be fine. Thank you.